Zoll has pushed the boundaries of what is possible for 35 years in the tradition of company co-founder Paul Zoll, a Lasker Award-winning physician and a pioneer in pacing and defibrillation. In addition to his seminal research, Dr. Zoll had a reputation for dedication and careful attention to his patients. His legacy lives on at Zoll.
Okay, sorry. Sorry, there's
What I'll do is I'll switch to the question and answers for a short while, and then we'll move back to you.
Okay. Okay, I'll start first. Sorry. There's some problem with the PC. You all can see the images, but I can't see anything here. Yeah. So the PCs are like, some people ask, are PCs, are they male or female? No? So people say, oh, so PCs are like female because they are temperamental. But then some people rebutted, no? But then PCs is like male also because sometimes they have floppy drive and sometimes they have hard drive. Okay. Sorry. So I'm going to, now this is actually a 40-minute talk, but it's crammed into 20. So I have to be streamlined and I'll be reading a lot. So please forgive me, I'll be going very fast. Okay? So, how? Okay. All right. So how does this? Okay, so now it works. Right, so first I want to thank the people of the committee for giving a chance to have this talk. Okay, so let's start. So mass disasters, as you know, overwhelm local resources, all right? And the spectrum of injury, however, for each situation, disaster patients is, however, usually quite uniform. That means if you have a collapsed building, most people will come in with crush injuries. If you have a bomb blast, most people have the same pattern of blast injuries. So while suddenly you can have a large group of patients, actually they are all quite similar. And once you get through the first or one or two, everyone else will start to know how to manage these patients. However, you have also got to remember that normal considerations such as giving every effort for all patients have to be abandoned. Right? When your resusc room is like only one or two patients and a patient come in, 80 years old, collapse, you'll give that patient everything you've got, right? But when you have multiple such patients coming in, then you have to hoard your resources carefully. So you give your resources only when they can make a large difference in survival to each patient. So in mass disasters, if you have more than a 50% chance, you probably give it all you've got. If not, then your normal considerations have to be sacrificed. So to help, what we have to use is mass disaster triage. Okay? So by and large, there are 4 levels of severity. It's noted by 4 colors. Okay? So usually it's like a traffic light mechanism. Red for P1 or in some countries T1. Yellow for P2. Green for P3. And black or blue for P0. Some places are called T4. Okay? Now, of note, however, is the presence of expectant or dying patients. You know they're not going to make it. All you can do is give comfort measures. But it can give you a lot of ethical and emotional conflict for triaging staff, especially if they're inexperienced or junior. So that's actually why in some situations they put the most senior chap right in front to decide who gets to live and who gets to die. Why? Because everything will flow from your triage decisions. From the speed of treatment to the speed of evacuation to the level of specialty care downstream. Whether you can send it to a peripheral community hospital or you send them to a trauma center. So this is a very important first step. Now, first, let's look at triage systems which can be based on physiological or functional criteria. We judge such criteria based on specificity and sensitivity. A sensitive criteria allows you to pick up a critically ill patient, like the P1s, while those that are specific lets you pick up lightly wounded, like the P3s. Okay, so of course in a mass casualty, you probably want to pick up a lot of P1s But sometimes it can be at the risk of over-triaging your P3s. Okay, so first we'll start with our called START. Now, START has quite a long history. It was first developed by the Newport Beach Fire and Marine Department at the Hoag Hospital back in California in 1983. All right, home of the Beach Boys. So it used a few physiological criteria to help you decide on the severity. And once you learn it, you'll never forget it. So what you do is you use the ability to talk, to walk, to breathe, as well as presence of circulation parameters. Some will use capillary refill, some will use a pulse rate. It's very easy to learn and apply, okay? But you must understand that there's actually limited rigorous review, not much scientific evidence, because simply it's not easy to conduct research in mass disaster situations. So for a scenario like this, what you do is, okay, you get a bunch of people, right, all injured. You say, get up, come towards me. Those who can get up and walk towards you will be P3, or if they are uninjured, shunted away. Right. So admittedly, it can be quite different from what you're used to. They can have a eye hanging out, they can have a hand amputated, but they're still walking, you see. So they are still P3. Whoever is lying on the ground, then you walk around. If they're not breathing, you open their airway and they're still not breathing, they're P0. Whatever lies between these two extremes are your 2s and 3s. So you feel their pulse, like capillary refill, talk to them if they can answer you, and whether they're tachypnic or bradypnic. So if they are stable breathing, stable to talk to you, and not in shock, they are P2s. Everything else is a P1. So it's very easy to understand. But what's the evidence for this? Unfortunately, the closest that you can get is Care Flight from Australia, which also uses something very similar in scope to the START. And Garner, who has done a research on this, found that there's 82% specificity, sensitivity that becomes a P1, and 96% specificity for P3. So that's the best evidence that we have. In UK, if you attend the MIMS course, you'll understand that they have a 2-step primary and secondary triage. The primary triage tool is called SIEVE, which is very similar to SORT. To START. So again, it uses the things, the same parameters of walking, breathing, respiratory, and capillary refill. So that is your primary triage. From there on, after that, they are having a secondary triage, which is using SIEVE. And SIEVE is what, let me get this back to you. SIEVE is what they use in the ambulance services on a day-to-day basis. So for SIEVE, you can see it's actually based on Glasgow Coma scale, using a bit of a Triage sort score. And from there, this sorting them based on the numbers into 3, 2, or 1. Okay? So this is what the ambulance services use daily. It takes a bit of getting used to. So in a mass disaster, the UK used 2 steps in order to sort out their patients. Okay? Next, we have SORT, used or rather endorsed by US Department of Health Services and CDCs. Now, again, when this committee was formed, they were asked to recommend a national triage system. Well, they went around looking for all the best evidence, and sure they found there wasn't much. It was just a lot of consensus statements. So what they did is they drew everything together and got it endorsed by all the large colleges in the US who are dealing with emergencies and trauma. Okay? And as you can see, first you have global sorting, then individual assessment. One look at this and it's not really going to work, right? It's very difficult. That's why outside of the States, not many countries use it. It's therefore has been by and large abandoned. Okay? So, in addition to physiological triage, I think one way forward is also anatomical triage. And this has been very much aided by your ultrasound imaging. Okay. Now the pros include, of course, that it allows you to look inside the chest and abdomen. Okay. Look for things like your pneumothoraxes, look for internal bleeding. Sometimes you are very good. You can even look for a ruptured liver, ruptured spleen. And therefore, it allows you interventions also, like setting in emergency chest tube or needle thoracostomy, and also allow you to assess the progress of the treatment, like IVC filling. But there are downsides also. Number one is operative dependent. Second, the machine is not always ruggedized. You drop it when you get out of ambulance, that's it. You can't use it anymore. The screen resolution can also be limited. When we first tried it out in the field, someone has to stand with an umbrella over the screen so that you can see the screen because it's not bright enough. The battery life is also short and you're unable to record images. So don't forget, when it comes to triaging, you have to triage, then re-triage, then triage again. Okay, but ideally, it will be when the patient is at triage point, then in the disaster site, in the P1, P2, P3 areas, and lastly, at the evacuation area. So triage is a very fluid situation. Now, there again are certain special situations where your usual physiological and anatomical triage criteria can be inadequate, and I'll try to outline some of them. One of them is, of course, pediatric disasters. You think pediatric disasters can't happen? Well, it can, no? Like let's say you got a cruise ship carrying many children for a tour, or a bus that overturns a school bus with children. Well, let's look at some of the ways we've triaged them. So, what they use is jump start. And the difference between jump start is that, first, when it comes to airway, you give the patients 5 rescue breaths. This is the basis for calling it the jump start. Also, because children's skin capillary refill can be affected by the cold, therefore they use peripheral pulses. And lastly, instead of using commands, they use AVPU, whether children can alert, response to voice, response to pain, or unresponsive. So there's these 3 differences between start and jump start. Now, all of you have known about pediatric tapes like Broslow, right? So smart memos also came up with a Broslow type of device called a pediatric triage tape. Okay, admittedly, one of the authors, C. Smart, is a director of the company. So so when this paper came out, he of course declared there could be a conflict of interest. So using the tape, just like that, you place the head here and you measure the length of the child. And then from here, you got specific vital signs. And from the vital signs, you triage them, again based on breathing, respiratory, and capillary refill to P1, P2, and P3. While it sounds promising, unfortunately, when they try to validate it, this is in South Africa, Wallace and Carley showed that, yes, it is very specific, meaning it's good at identifying non-priority children, but it's poorly sensitive at identifying immediate priority children. Okay. Nevertheless, it could be still a tool for you to sieve out the P3s and concentrating your attention on the P1s and 2s. Now, hazmat triage, and here I must declare that these slides come from the hazmat life support course, which I'm part of a committee and which we did some work in putting out a new edition just 2 years ago. Okay, so when you come to hazmat, on top of your No, don't take pictures. Come attend the course. Right? Okay, so when it comes to the hazmat casualty, before you arrive you've got to think, is this a CBRN? And if this is a C means chemical, biological, or radioactive nuclear incident. And here, our trainees have been taught to use the 6 sensors as well as the on-scene info before we take on hazmat immediate actions. Okay, so these 6 sensors include, what do you smell? Is it a chemical smell? We don't actually taste a chemical, right? No, but we do ask the victims, do you taste anything? Hearing things like stridor, hearing things like any sounds or airway, which can suggest to you some chemical that's corrosive or irritative. What do you see? Patients having fitting, patients who are very drenched and vomiting and having salivation. All this can indicate to you nerve agents. Okay, sensations also as well as suspicion based on what you know of hazmat. Okay, and from there we take on actions to protect ourselves. Sounding alarm, safety first, self-protect, and symptom check. The symptom check that we emphasize on is the sludge syndrome, for which we have a specific nerve agent antidotes. But you can also look for other things that can be treated like mustard and cyanide. Okay? And from there, this is layered on top of your triage sieve, in the sense that on top of that, we also look for D, dark, drenched, disability. These are all quick synonyms for the sludge syndrome, for which then we give antidotes. All right? So this is a secondary survey as well for the sludge syndrome or dumbbells. Okay, how about radiation exposure? Now, while in Singapore we don't have much risk of radiation exposure. It can happen because some of our, like Changi Hospital, we are very near Changi Naval Base. And you may or may not know that every now and then nuclear warships come to Changi Naval Base. So the head of department of Changi Hospital, every now and then I will get an email saying, please note that you have a nuclear warship coming from this to this date. Now, the thing about radiation is often misunderstood. Okay, it doesn't do something to you like the Hulk. You don't transform straight away. It doesn't kill you, giving you thermal burns. So actually, it's an injury that is slow process which you can mitigate. Actually, when it comes to panic reaction, more likely you get, when it comes to radiation injury, you are more likely to get panic reaction than actual physical injury. All right? So you can do it in two ways based on the symptoms. So again, you get a bunch of people who's exposed to radiation and you sit them down in a large room, maybe with a cinema or television, and you observe them for 6 hours. Okay, this is one of the slowest mass disasters you have. So look for vomiting, diarrhea, any fever or headache. If they get none of all these things, then probably you've got mild or not much radiation exposure. But if they get many of these things like diarrhea, vomiting, fever, then you count that as lethal. Okay. Following that, a full blood count taken at the time of incident and follow up in 2 days' time. With this full blood count nomogram, you can then decide whether they are at risk of death or not. And this is validated by the experience in Sherbernil. So you can see that this radiation mass disaster is one that you can follow up as an outpatient, unlike many other mass disasters. All right? Burns. Mass burns, again, it can happen. And when you have mass burns, this is how you triage them. Less than 50% of chance of survival if they got more than 7% of total body surface area burns. Age of 60 or more with inhalational injury. Age less than 2 with 50% total body surface area burn, or 60 with 35% total body surface area burn. For these patients, you just give comfort care. Another easier rule of thumb is a Boer modified index. You take the age plus total body surface area burns. Okay, sorry, one word, the burns is only second and third degree. You disregard the first degree, all right, which is like sunburns. If they have inhalational injury, add on a 17. So the patient is like 50 years old and got 30% first and second degree burns, then his mortality is already 50 plus 30, 80%. Okay? Smoke inhalation without burns, yes, it can happen, especially when they are entrapped inside an area. So here what we do is that we had some experience with this back in 2006 in near Changi Hospital where there's an incident. So from here, we divided them up. You can use a mixture of physical examination and pulse oximetry or carbon monoxide oximetry, ABG, chest x-ray, laryngoscopy or fiber-optic bronchoscopy, and carboxy hemoglobin levels. So based on physical examination and these tools, you can triage them to 1, 2, or 3. Okay, if the examination scope is normal, then you don't have to do much. But if they have all these things, then you consider them as 2. If they are unconscious and unwell, then it's 1. In bomb injuries also, severely injured, airway compromised, breathing difficulty, those who are in shock and other level of consciousness. But they are likely injured like minor wounds, first degree burns, isolated trauma to a limb, and most working patients, they can treat them easier. Okay, so these are the triage aids, triage tools. Then finally, there are aids. Okay, and some of you will know the MedTech, right? The advantage is very simple to learn. Okay, and you got 3, 2, and 1s. You can only up triage. You cannot down triage. The whole thing is made of paper, so it can get wet easily. And this thing is only a raffia string which you tie to the arm or hang around the neck, so it can get lost. Okay. There are also 2 tags here. This is at the torn off by the triage officer. This is torn off by the evacuation officer. Allows you to keep track of the numbers. If I tear off 30 and the ambulance officer tears off 30, then the number is correct. But if I got 30 at triage and 28 only at evacuation, then 2 patients are missing. So you got to go and search for them. Okay, and there are very many variations on the same team worldwide. Okay, like I said, it can be hung on the neck or tied to the limbs, but also can easily get lost, and also very limited space. And you'll be surprised. Sometimes the patients can falsify data so they can get up triage. All right. Some other new ways, New Jersey, they have peel off and on stickers, foldable tags from South Africa and UK, and can even put in plastic bags so they don't get wet when you do decon on such patients. All All right, stat bands also, by laser band, Minnesota, all various types and kinds. However, I think actually electronics should be the way to go. And this is where some of my colleagues have been experimenting with this based on smartphones. You put in data and RFID. The thing is, however, you need a power supply and a connectivity system. So let's say you are in a mass triage, your network is overwhelmed. You cannot use a 3G. So here it can fail you. However, the Japanese have been leading in this. So they use a RFID tag, a smartphone, and from them, they can use the smartphone display, triage the patients, and follow the patients all the way to hospital. Of course, it's value. Of course, this means you have to have money put into the system, and it should not fail you. That means you must have backup power supplies. The good thing is that all these things can calculate the 3-score and other analytical scoring for you and give you a better outcome. And finally, you've got colored lights that can let you triage at night. Okay, thanks. Thank you.